So let's jump right in. We've got a large, illustrious panel here with us today. We're barely fitting on the stage, so I'm loving this dynamic. But let's start with something that is really important for startups and health systems alike, which is how do you get to a pilot? Hospitals are flooded with pitches for AI tools. That's overwhelming to even keep up with the number of tools out there. So from each of your vantage points, what separates pilots that actually get greenlit to those that never make it past the first meeting or even to the first meeting? And maybe we'll start with Jae for this one, for the perspective from the health system side.
Oh dear. So that's a very loaded question. So I will tell you that I think we're basically inundated with pitches. In the past maybe year and a half or so, give or take, I've probably seen I don't know, over 600 I think at this point. It's hard to keep track, but over 600 opportunities we look at or diligence or pass, etc. And so ultimately it comes down to a nexus of a few core issues, which is one, are you actually solving a problem that's a priority for that particular time and place, right? I mean, we're a very large enterprise. Large enterprises have infinite problems. And so are you solving one for me that is a current priority at that time? And then it comes down there, the business case becomes a little bit obvious, but then there's a technical stack. Like, how much can I trust this product? How much is there a true moat to this product? What does the roadmap look like? Does that roadmap continue to benefit us as we go down the road, et cetera? And then of course, finances obviously play a role. What does it cost us? And then from an enterprise standpoint, keep in mind that cost is very, very different than a smaller group or company, right? The change management alone, the sheer number of meetings we have to cascade down at an enterprise level from high to low is huge. And we have to pay for that time. So it's not cheap, right? So even a simple pilot, just the change management alone can be very costly. So keeping that in mind, all those factors have to align, all those axes have to be pretty much perfect, unfortunately, for better or worse. And that's kind of how it starts.
All right, why don't we just go down the row here?
Yeah, so from the vendor's perspective, I think my view is pretty consistent with Jae's view from the other side. So first of all, so what are you setting? Are you setting a painkiller or is it a vitamin, right? So that makes a big difference. Hopefully it's a painkiller. And number two, if the painkiller is addressing the pain, is it doing a better job than other solutions out there, especially solutions from the customer's existing vendors? If hopefully the answer is yes to both of those, and then there's still number three, like Jae said, priorities. Is the timing right? They're high priority. They have limited bandwidth. Right? They have a lot of non-financial costs with implementation, deployment, all that. And from our experience, evidently, so for example, a couple of years ago, ambient scribes had a lot of the mind share in the space of clinician-facing AI tools. So when we talk with the health system, some of them would be like, we're formulating our AI strategy. We want to start with the ambient AI first. We don't want to do anything else. And then some of them are even like, what AI? We got AI already. Isn't AI the same as ambient AI? Okay, so that was a couple of years ago. Right now, 2025 is very different. You have ambient AI that's like table stake. Now a lot of health systems, they're looking at what else can AI do for us. So now if you go and pitch them like, so look, we have this AI, they can make sense of all the unstructured data, all the thousands of clinical notes for a patient, all the outside records, all the scanned documents. It can summarize them just like a resident would do, but doing the work that the resident would do in, I don't know, 16 hours in 6 seconds. So that would be something that would be interesting. So in 2025, so that's something that we'd like to explore. They may want to do a pilot, etc. So that's our perspective.
Yeah, we touched on a lot there already. Maybe from the vendor's perspective, some other things, how tight is the time to value? So, depending on the integration footprint, you mentioned the change management operationally, but oftentimes some of these products can be a pretty significant lift just to get up and running. So trying to keep that tight. For people here who have companies and are thinking about this, like, how did you get in the front door there? Do you have the right people at the table? I think that there's, we've had pilots or pilot discussions where we've got heavy operational interest, but They have not engaged anyone in IT or other different key stakeholders, and you just got to make sure that they may already have a solution that's getting deployed in another corner of the organization that the strategy's been built on. And you have the flip side where you've got either something that's coming in tops down or like a real heavy IT interest, but there's people who don't, we work with digital teams sometimes, and revenue cycle or certain clinical workflows can be very, very nuanced. And if they don't have experience with that, it can be hard to, if you've got those people, you'll have an 11th hour where people find that they're not interested, and you've had a lot of really exciting conversations, but they just kind of go to die.
So you wanted us to kind of mix it up a little bit, okay? Okay.
Do it.
So I think lots of companies come in and they say, we're your vertical solution for this little slice. And you get 600 little slices. And the impact on the organization, they already have 200-300 different systems that they have to integrate. And so, yeah, you could get all the value and all that other stuff, but the impact on the organization to fit into the workflow, into integration, if you've got a perfect solution that's vertically integrated, it's gonna fail. Because hospitals are too complicated right now to be able to sort of take 100 vertically integrated, tightly localized solutions. Second thing is data. So if you can build a system that doesn't need to interact with any healthcare data, then you're probably good. But as soon as you have to get access to that, there are standards to consider. If you're working with Epic, you've seen one Epic installation, you've seen one Epic installation. It doesn't generalize beyond that, and there's a lot of customization. Despite the fact that I did a lot of the standards in this country, it doesn't work. And so I think too often people come in with a, we can save you $1 billion on X, Y, and Z. Whose ox is gonna get gored? Like, who's gonna lose their job, right? That's where you're gonna have problems, because the cancer registrars are gonna say, we don't want you to automate our job out of this, it's terrible, right? So there's a whole bunch of different things like that that are hidden. I think a lot of people naively come into healthcare saying, I've got this point solution that's gonna save you $1 million, and they don't think about the integration, sort of the horizontal nature of this, the other things that are burdened on the organization. And frankly, the easiest thing to say is, I'm just gonna wait till Judy Faulkner tells me what to do in 3 years.
Can I riff off that real quick? Okay.
Sure, and then we'll get to Subha.
So everyone should be booking a consulting contract with this man. Just joking. No, I'm not joking. Anyway, he's not wrong. And so honestly, a lot of it is one of those things where you got to understand also, I think a lot of people from the engineering or tech stack standpoint come in thinking, surely APIs must exist for this. They exist everywhere else in tech, or surely there must be a wonderfully organized thing where I can just import this library and it will happen. No. Like at the enterprise level, I think people underestimate how much is held together with the digital equivalent of duct tape, right? Like RPA, there's a reason there's major companies with competition that thrive in just healthcare, okay? And we pay them because
Epic
it works.
underlying is built on mumps,
Yes, that too.
40-year-old technology.
More than that, right? Technically. Yeah, no, I mean, so I think people underestimate deeply, the amount of duct tape there truly is, and that's in production, and it works. And touching things that are held together by duct tape, we're not always eager to see how brittle that is, okay? Because fixing that, again, and patching it up to make it work again is not always a pleasant process, okay? And so I think some of the folks who have experience at the senior director level or executive level in the tech stack space also understand this to some extent. I see this as less of a commonality in startup world, where perhaps the experience levels are a little bit different, but I would really urge you to do that, to have a great look at that. And to Doug's point, everyone who touches your workflow, you should have done your homework with. Right? He made a very crucial point here, which is labor. Listen, we're in California. We are a union state and we support unions, okay? So that has to be part of the messaging strategy. How are you going to support everyone, okay? If you're coming in saying, hey, I can blow this up and you can just fire 1,000 people, listen, that's not going to fly. Okay, just from a moral perspective, but think about it from an optics perspective, that's obviously not going to work well, yes? Let's just be candid about that. And so when, this bravado that I think a lot of startup folks are used to wielding as their messaging strategy is simply foolish when it comes to healthcare.
So Subbu, you want to build on that?
Yeah, finally got my turn. So I guess a bunch of these things have been already talked about the problem clarity. Like we are not using AI just for the sake of using AI. We are really identifying a pain point. And the pain point is a two-way door. We are, at the end of the day, the clinician, the healthcare workers, they need to be, at the end of their shift, they should feel that they are lightened. And on the other side of the door are the patient, they need to feel heard. The second piece is the validation. Early validation always helps in a pilot. The validation can come from multiple forms. It could come from peer-reviewed validation, publications, or even like external references. We might have done a bunch of successful pilots. Now we are going to another one, and the references help there tremendously. And the third, maybe a bit understated one, is a champion. It's very important to get a champion in the organization. The champion could come in the form of a trusted nurse leader. It would come in the form of a CMO who really backs you. And there are multiple places where the pilot gets stuck. The pilot gets stuck in the form of the AI governance council that meets once in 2 months, once in 3 months. And then it is up to the champion to really push it through to make sure that you are early in the queue, or even tell you that this is where you need to get your RFP and everything in, so that all the workflows and the work streams could be scheduled and prioritized. And just not one, multiple, because organizations go through change. The champions might be reorg, they can move to a different business unit, different organization. And then you are again back to square one where you're starting from scratch. So all of things need to be considered like to get a successful pilot out of the door.
Yeah, so actually it's a great jumping off point too, to think about beyond the pilot. So how do you go from that initial pilot, having your champions, showing them that your tech can work on a small scale, to something that a healthcare system is going to be willing to adopt at a broader scale? And I think that really kind of touches in on some of this conversation about the people and what's the impact on their lives, like the people who are either worried they're going to be replaced by the AI or whose lives will be made better by the AI. And I know I had conversations with many of you before this conference about that particular point. So maybe we'll start with you, Adam, and then move our way randomly through the queue.
Sure, yeah. So I think we're going to get in the human side here. So after you go live with your pilot, the energy or sort of the timbre of the conversation really can change directions after that. Like the best go lives we've had, we're just getting organically pulled into an expansion. The value to the stakeholders that we have engaged, whether that's providers, staff, patients, like is so clear that there's an interest in expanding that. Not all go lives are like that. Sometimes it's hey, we didn't think about these workflow considerations. This is frustrating. This is, we hit this edge case and we didn't train people. The communications were poor. So I think like there are a lot of things in the change management that you can, potential minds in the field that you can hit. But let's say you're like on the good path. So you've got a lot of pull. A lot of our partners, and I think just looking at some of the our companies on the stage, they're working with health systems that are large, right? So the scale from pilot to full enterprise expansion could be 100x as many caregivers that you're impacting. So you got to figure out how to work with the existing kind of like operational structures that they have. How do you train all these people? How do you make sure that if there's feedback or issues that you're getting that back to your team? How do you like communicate the value and incentives for all these people and see if that is coming true to fruition? I think there's sort of like the standard project, managing that at scale that you want to do. And then I'll hand this off to someone else, but I'll just sort of tee it up. I mean, I think for a lot of the AI projects, you mentioned that there's a lot of anxiety around, especially if you're going for efficiency or additional productivity, like what does this mean for my job? And that needs to be handled sensitively, thoughtfully, And I'm sure there's a lot of things to share on that.
Yeah, Feng, I know we had a conversation about this, so I don't know if you want to pick that up and run with it.
Yeah, I don't have a lot of things new to say, but I would say one of the things will be just, especially in the last couple of years, like kind of all the big health systems are, I guess their AI strategies are evolving, but also there's also, especially in the last 6-9 months or so, there's a macro environment with all the additional challenges coming from the federal government and everything. So especially in the last say year or so, things that you could have, say maybe the pilot was started say before those challenges, and after that, and some organizations are starting to thinking, okay, we're excited about this, but now we have to cut back on everything. So that will be kind of one factor. Yeah.
Are you sure you want me to talk?
Absolutely.
So I think it is naive to go in. You got to do all the things about good project management. You got to do all those things. But if you just do that in healthcare, you will fail. To get your pilot in, find an isolated part of the organization that you can draw a circle around and it doesn't affect a lot of other things. Find a clinic, find a hospital, find an area. Because if you can do that, you're gonna make your CIO's job a whole lot easier because they can kind of encapsulate that and it's not gonna bleed into other things. And then you have to figure out, there's a lot of folks that sort of say, we're gonna take functionality enterprise-wide and then gradually add functionality. That's a hard way to do things in healthcare. It's much easier to sort of take an isolated area, take a clinic, and then expand to the next clinic and expand to the next clinic. Because again, you can draw a circle around the stuff there, and then when you have problems, you can start to isolate those a little bit better. So you have to do all the things that are important for good project management and kind of getting things out there. But if that's all you do, then you're gonna run into also all sorts of struggles. The other thing I would say is that physicians and clinicians in general are quite skeptical. That's just kind of how they come in. So instrument your system. Make sure that you know the ins and outs of all the different components so that if something goes wrong, you can give a diagnosis and an explanation as to what the problem is. So black boxes, make them as small as possible so that you can understand the ins and outs, because they're gonna want explanations as to why certain things are working the way they are. So I just think you gotta do all the basic things, but then you gotta isolate the problem and the pilot and then expand incrementally, land and expand in that way. And then you've got to instrument your system because they're gonna wanna know deep down how all the pieces are fitting together.
I'm going to once again riff off that. Thank you, by the way, for all these wonderful foundations on which I can jump on. So it's worth noting that as you watch the success of something like ambient AI documentation, there's a bit of a uniqueness to that Doug's pointing out, in that that particular field was effectively greenfield. It did not exist in a meaningful way previously. I will admit, yes, there are aspects of which obviously certain enterprises have scribing companies that are typically very poorly paid interns who are typically pre-meds. I may or may not have done this. Anyway, my point being is that, but the AI aspect of it, and it wasn't a common practice. In fact, if you look at a survey of what was like previously, oftentimes these were physician groups paying for it, not the enterprise, or even down to individual physicians paying for the scribing service separately themselves. So on an enterprise level, ambient AI or AI kind of scribing documentation in general was largely a greenfield event, and it's unlikely you're going to find something very similar to that in the AI world right now, because everything else requires touching the data to a deep way, and it's very hard to narrow it down to a very specific vertical or a very specific environment. And so just be cautious about how you tread that, because again, you're touching a lot of different stakeholders at multiple different levels. And I think this is where people often trip up as well. They think, oh, if I just get the doctor's buy-in, we're good. I just got the chief nursing officer's buy-in, we're good. At an enterprise level, we're kind of going, that's great, that's one of 10,000 doctors. That's one of 21 chief nursing officers for each of the med centers, et cetera, et cetera. So the stakeholder management is something that you really need an active strategy for, and the education of how your product is going to fit into everyone's workflow. That education piece needs to be a very integral part of your go-to-market strategy.
All right, so I'm going to have Subho start us off with what builds, I think, quite nicely on that, which really gets to the core of something that each of you have touched on, which is trust and workflow fit, right? So for you to even get the pilot, but then certainly to go from pilot to scale, you need to be really making the lives of your stakeholders throughout the hospital system easier. And you know, sometimes I think, especially in AI, we think about trust as a little bit more of a technical issue. So we're thinking about accuracy and explainability and validation. But you know, it's also about making a tool that actually makes the patient or the clinician's day easier. And so, you know, I'd like to start with Subho, because I know you guys think about trust a lot at Hippocratic. And so maybe speak to that a bit, and how do you design for both? How do you...
Motto for companies, do no harm. We start with do no harm. So trust is again a two-way door, right? There is clinicians on one side. They need to be able to reliably trust the system for it to autonomously make calls to the patients. The patients need to trust the system that the calls that they are getting, the agent on the other side is safe enough to pursue the conversation. In the form that if they are not feeling well or distressed, they would know that, okay, this agent is going to, say, hand over or transfer to a real human and not going to take or continue the calls when the conditions are dire. Now, how do you get to this level of trust and safety? Like, healthcare is one field where even 99% accuracy is not good enough. That is still like you are killing 1 out of 100 people. So we have been spending like 2 years just to perfect the system. And when people say, talk about safety, they talk about the LLM. But the safety is just not an LLM problem, it's a system problem. The system can fail at any point in time. For example, the ASR could fail because there is a tremendous amount of background noise, which is very common when the patients are talking during commute or during crowded environments. Maybe I didn't hear the blood pressure 147, it just heard 17. And that is a system failure. And when people just talk about safety, they're just talking about LLM confabulation and LLM hallucination, but you need to treat safety from the system aspect of it. The other piece is transparency. You need to be really transparent. So they don't always understand what is AI error. It's any error that can happen to them is an AI made a mistake. But it is not always the case. So it needs to be incredibly transparent to them. So for instance, all the millions of patient calls that we are making, we have a safety portal where each and every error that we make, it is logged. They can go and then they can triage, they can validate, and then they can have some action items on them. So transparency is another big theme.
Yeah, and actually one of the things you mentioned there, I think, Feng, we talked about, which is like, how do you benchmark to the right? You know, 99% accuracy may not be good enough, but where are we really at now, right? And how, you know, how do we benchmark against where we're at and show that we are doing better as we implement these tools and build trust in the system?
Yeah, like accuracy numbers, there's just one aspect of it. So what we do is that we summarize clinical data. So clinicians, they don't have to spend hours every day to do all the clicking, mind-numbing clicking, skimming, and scrolling. So when a clinician sees our AI summary, so how do they know that this is the truth, the whole truth, and nothing but the truth? So we have built a few key design principles into our system to ensure that. Number one would be that when we present a summary to the clinician, we make sure that that's always verifiable. It's always traceable to the source data. So we have a beautiful data system. We have an intuitive UI to make sure you get the truth. And number two, so we process the complete data. So for example, let's say you're a clinician seeing a complex patient, reviewing their diabetes history, you understand their A1C. Of course, we're going to take all the A1C values from your EHR, but we would also go out and harmonize all the A1C values from your outside records, like your Care Everywhere. And then we would also extract those values from your scan documents, like coming from LabCorp, et cetera. So then you have this beautiful line curve for A1C from all the data sources. So that's the whole truth. That's really important because if you only have the partial information from us, then you still have to go somewhere else say the media tab in Epic, to grab some scanned documents, go to page 7, and try to get some of those values. And are you going to train that on your paper? Like, so that's a lot of work. So that's why the whole truth is really important. And then, so that's why the whole truth is so important. And then, so when you talk about like is it harder or easier for your workflow? How aligned is it with your workflow? So we view that as a kind of customization need. So customizing for the individual users, for the individual workflows. We have quite a bunch of mechanisms for that. And first of all, just we have a vast library of meetings of built-in summaries for you they can choose from. And then you can spec out your own custom summaries. Could be just a simple prompt. And you can build any dashboard to mix and match those summaries for your different workflows. Let's say you're a specialist, you could have a dashboard for your clinical work, and you could have a dashboard for your hospital consults. And then on top of that, so Jonathan was here, so Stanford had this chat EHR thing. Similarly, we have this chat interface as well, so writing within EHR, you don't need to select any nodes, it's just a text box. You can ask any question, so we can give you the answer, and then you can do follow-up, etc. That's so that you can get your ad hoc information needs satisfied. And so we have all those mechanisms to make sure that we can meet your workflow, meet your needs, and you get nothing but the truth.
I'll try to take this and build on this and take it a little bit different direction. So when we see the human side of this, I think it's sort of the challenge of trying to connect the technical and the human. So Doug mentioned about like who's going to get gored, by, and when mistakes are made, if someone greenlights something that goes through and in that 1% or sort of the anecdotal examples that come up are problematic. Like what is the defense or the sort of evidence that is going to make that okay? And for people who are new, a lot of these decisions are made in committees. So there's like a very wide range of people who need to like put their stamp on something, whether it's the pilot or for the go live. So there's sort of that level where you need to get buy-in. And then there's also just all of the individual people who may be using your product. So like this is, I think, probably skews towards a more technical audience. Like how many people here understand the concept of precision and recall? Like pretty good. If you are working at a call center and managing a team of 15 people in a cube farm, and or you have a bunch of people transcribing faxes for incoming referrals, or you've got a coding compliance operation and you're sort of making sure that when you deploy AI to mitigate against bad quality or mistakes which could contribute to patient harm, those people aren't going to be involved in analyzing the evidence that you're providing them, which shows that your models are performing better, or intuitively, there's a gap in understanding on what that evidence is saying and how that will affect them. So the things that we've seen that can happen are you may be doing something with a lot of quality, but people are double checking your work. It's not resulting in the efficiency that you intended. People are resistant to going live. They're throwing out edge cases or things that are coming up, and so there's like there's not a common ground on what the baseline is, or you may have like higher burdens of proof or sort of doubled standards on what you need to achieve. Some of the things I'll just sort of share, and I'm sure a lot of people can engage on this, is we've tried to help the people who are going to be impacted on this workflow and have the subject matter expertise to have a more intuitive way of understanding what the baselines are and what the performance is, sort of the before to after. So what does that look like? You think about like a double blind, or you think about like, sort of like the Pepsi challenge. Like imagine like you take the vendor out of it for a moment. So like we have a partner and we were working on their coding compliance. And before we even got involved, we wanted to baseline like what was their baseline agreement rate. So we give 100 different claims. we have 10 members of their team and they all like score, those 100. Like how often are those 10 people scoring them the same way? And I think like when people can individually see, they know their peers, they trust their peers, they can see that there's variation there. It's just a different entry point for the conversation. And then you can kind of see, the before and after. They're part of that process. So that's harder to scale, as you're going from, a few people to a few hundred to, maybe thousands. But there are ways that you can sort of bring this and present it in a way that's not just like, here's our numbers.
So I'll make 3 points. The first is trust is about responsibility. And until computers can take responsibility, it has to be assigned to a person. And if you believe that, then your technology should do one of two things. You either augment somebody who can be responsible so that they can do a better job. Jonathan's not here, but I was going to give him a hard time. It's like, yes, chat can do better, but it can't be responsible. And if something happens, you need you need a belly button to be able to pin the blame on. And whether that's a person at the company or whether it's the person in the clinic, somebody has to take responsibility. And until that happens, people aren't going to trust it because trust to them is responsibility. Second thing is we try to do a lot of work on using AI to automate things that people are already good at. Why do people become doctors? Well, sometimes it's because they like the diagnostic dilemma. They like to kind of think about that cognitively. And if you take that away from them, they will resist having that in. Now, they might like better information and help them kind of think through the problems. But if you take away that diagnostic dilemma, they lose the things that they want to work on. So try to think about, and this goes back to the ambient question, the ambient technology. Find something that isn't already being done, right? So there are apps out there that, it's a skin condition, you take your iPhone, and it'll tell you the 300 different diagnoses that could possibly be, right? Dermatologists aren't going to use that. But what you need is a patient needs an app that says, should I see a doctor on this or not? It's far less complex. It's a simple thing. You can take responsibility for that early triage, if you will. And ultimately, the doctor is going to be able to use their clinical judgment to determine whether it's something that is serious and needs to be attended to. So it's about responsibility, augmenting people who can become responsible, and finding the holes where there isn't something that's automated, and figure out a way to do that. We don't need more dermatology diagnostic apps. What we need is a patient to be able to triage at home and get to a dermatologist when they have a suspicious lesion.
Man, okay, hard to follow that. I'm gonna throw something out there as a personal opinion, not reflective of anyone else. Let's just throw that out there. But as a personal opinion, and this is coming from someone who has actively practiced medicine for well over a decade now, diagnosis is held, I feel like, in the public eye as some sort of incredibly mysterious, horribly difficult thing that just is magical, and only the process of going through medical school and learning how the engine works underneath the hood can you then, when the stars align, achieve this mystical thing.
Yeah, thank you, Dr. House. Yeah.
House, yes, Doogie Howser, depending on which generation you might be on, it's all good. Not here to judge that, it's cool. But I think, again, as a personal opinion, I would tell you that I don't really think diagnosis is the hard part of medicine, and I don't think it has been for at least a decade, and it will, from this point forward, probably never really be the hard part. And the reason I say that is because that's great. It's amazing when you're able to put a name and identify the entity which troubles your life and which troubles you and limits you in certain ways. That, I will never deny, is a very human thing to want to know the name of that entity. But the management of that entity is what's actually hard for the vast majority of Americans that walk around today, unless you're in certain, socioeconomic tiers. But my point is that diagnosis tends to be more of a search problem than an access problem than it is truly an academically challenging one. Because ultimately you find a lot of these same stories over and over, which is that because of a lack of access, because you can't get appointments, because specialists are limited, people bounce back and forth between their primary care doctor or much more frequently the ER over and over and over again. And respectfully, this is one of those things where if we think about it, you would never hire someone to go like plumb your house, okay, and fix your plumbing when all they've done is paint and all they're used to doing is painting. So seeing an ER doctor over and over and over again for something that is perhaps not within their comfortable wheelhouse doesn't lead to good outcomes, right? So is the diagnosis really the problem there, or is it really the fact that they cannot access the appropriate specialist? I would argue it's the latter. And so, yeah, it's one of those things where it's a very challenging issue, but thanks again to Doug for letting me riff on that for a moment.
I have one thing that I want to add there. I missed, there was 4, actually. I'm going to give you a little bit of an anecdote. So where do these AI systems get their information that they can do the reasoning on, right? It comes from the doctor, and doctors edit what they kind of perceive and what they put in a note. There's a lot of things that sort of say, when you write your note, you already know what you think the diagnosis and plan is, and you edit your note so that it makes sense by the time you get to the end of that. So there's already editing that happens, and a doctor will edit that information, even if they're using ChatGPT or other things like that. And so computers are really bad at getting information in. They have to rely on humans to make that happen. I mean, there are labs and CTs, and that's probably where AI has taken some better strides. When I was seeing patients over at Stanford Medical Group, I had this patient. She was a burned out schizophrenic. So what that meant is that she had schizophrenia for a long time, but now was dealing with things like hypertension and just tardive dyskinesia, these abnormal movements and things like that. But she was a beautiful Southern lady who would come to her appointments dressed to the nines. So she would have her yellow pumps that would match her yellow dress. She'd have a sable cape, a little pillbox hat, and a purse that would match the whole outfit. And that's how she always used to come and see me. So when I would be there in clinic, if I saw her coming down the hall to go into the room and her hat did not match her purse, she probably had a urinary tract infection. There is no ChatGPT that's going to make that kind of association. And I know that because I had enough experience with that to just sort of know when she is not kind of all put together, something's going on, we got to figure it out. And the thing is there is no ICD-10 code for pillbox did not match her purse or her pumps. And so there's no way you're going to get that into the system. So I think it's really important to recognize too that all these systems are relying on people who will edit what they put in based on their preconceived notions of what might be going on.
Yeah, so that's actually, I mean, we've gotten into some of the really gnarly issues, the things that make healthcare challenging, but also really exciting. And of course, at the center of this, I think for all of us, and nobody really goes into healthcare without having that patient front and center. So, you know, building on everything that has been said, how do you think AI will change the relationship that patients have with the healthcare system in the years to come? And you know, what does that look like? What's the best possible trajectory? Maybe what's the doom scenario we really like to avoid? So Subha, we'll start with you again.
So the patients want to be heard, they want to be cared for and listened to, and the AI has infinite amount of time that the clinicians and the healthcare workers who are burdened today do not have. AI doesn't go on a holiday or say Saturday, Sunday, call me up on Monday. But the form of communication is incredibly important. So the way humans communicate in text is not the same as they communicate in voice. In voice, for instance, the tone, the prosody, the intonation, the pauses, which gives more human-like communication pattern is incredibly important. This is not the way how, say, you do it in ChatGPT text mode. So if the patients are to engage with the AI, say in phone conversation, which is the primary form of communication today between healthcare workers and clinicians, that voice mode needs to evolve. the patients need to be able to trust the AI more and more, and this trust, rapport, empathy, and engagement is like a two-way door. Memory is something that Doug brought about briefly. Like, this needs to be a continuous protocol, a continuous touch point of care, moving from the episodic check-ins that we see today. The agent would call up the patients every other day to see if they require any follow-up, to see how their adherence protocol is going. So it needs to be more and more continuous and more proactive rather than the reactive patterns in communication that we see today.
2 points. The first is when the World Wide Web first came out, right? And I'm old enough to remember that. I used the command line version when I first started. I would include that in my review of systems and talking to patients. I would say, what did you read on the World Wide Web, right? And they'd pull out this ream of papers kind of sheepishly, and they said, I am certain that my headache is glioblastoma and I only have a few months to live. You know, and so then the thing is that you can address it right up front and you can make it part of your conversation. We're gonna have to do that in medicine now with ChatGPT. We're gonna have to ask patients, what has ChatGPT told you about this disease? What are your concerns? What are the things you're worried about based on that conversation that you have? So I think we have to include that in the way in which we practice medicine, because people are gonna use the technology whether we want them or not. The second thing is that my optimistic view of what this is gonna do. I think too often medicine within medicine, we do things to patients. So the patients are the object upon which we practice in our medicine and therapies. My hope is that ChatGPT and AI will raise patients to be first-order participants in their care, so that they become a partner with the physician and the AI and all the other sort of social support systems that they have, and that this actually elevates the conversation, so that doctors don't have to be on sort of a high pedestal and have this, you know, dramatic. We become counselors. We become like interpreters. We help patients take the information that they got from ChatGPT and apply it, to your point, in a way that makes sense for their particular situation. So I think I would love to see a situation in which these sorts of things, whether it's to, and by the way, when you talk about clinical care and hospital care, clinical care is about, well, how many of you have seen your doctor in the last week? Okay, one. How many people have seen their doctor more than 4 times this year? Just a few, right? People don't spend their time in clinical environments, and we spend a lot of money on clinical environments because that's where the money is, right? 1% of that, you know, of that 10%, there's even a smaller portion that ends up in the hospital. What we need is if we can raise the ability of patients to be first-order participants, we can start to capture that 90% of the time that they spend outside of the hospital and create to your point, a continuous conversation that's a little bit better. But we have to acknowledge, one, patients are gonna use it, and two, let's use this technology to empower patients and not to make them feel as if they're, that ChatGPT is those horrible phone systems that you're calling through to get to support. That's not the model that we want this to do. So that's, to me, the dystopian way of going. But I think we really want to have it as something that empowers patients.
All right, let's keep moving down the line as we wrap up our conversation today. But Adam.
Yeah, I would just I underscore what these two both said. I mean, I think as a patient too, you're gonna have a lot more tools that are out there to help you understand, what did you just talk about? Maybe that was a big conversation that you just had live and you weren't able to fully process it. What are the ways, whether you have a recording of that conversation, which can get transcribed, whether you can, you know, ask follow-up questions that don't have to get directly answered by the provider you just saw. But I think like different ways to engage, and sometimes for patients, when we were just talking about some of the summarization of the chart for providers, I mean, if you're going through an acute episode of care and there's a lot of information and lab tests and things, and maybe your My Chart is full of all kinds, like what are some of the ways we can make it easier for you to remember that or see what's going on? And then maybe this is maybe the obvious, but I'll just sort of lay it out there because it's something that our company spends a lot of time on. It's just like on the administrative side, I just think a lot of the things are going to be more streamlined so we can be more responsive. So you're talking about like sort of the availability over the course of the week. There's also just like how long does it take for things to happen? So imagine you got a referral and you get a referral to Stanford, UCSF, or one of these systems around here. Like how long does it take from that fax to come in and get like transcribed, to get entered into Epic, to get like a prior auth kicked off, or a phone call to go schedule your appointment, right? Like instead of that being a really prolonged process, you could imagine that being very responsive. So like you leave your doctor's appointment and on your way home, you've got your prior auth approved and you've got like a few times that you can go schedule at your own convenience in your pocket. And obviously that's gonna depend on the service line and the availability and all that. But how much clearer that could be, that's exciting, to me as a patient.
All right, Feng.
Is it working? Yeah. So yeah, I'm completely aligned with Doc's vision that in the future, like patients will be a lot more active, and not just a passive object that's being seen, but they will actually be more vocal. They're being their own advocate. There's a bunch of stories like so Caddy was telling about this story that the patient will go to the cardiologist's office, a patient with the AFib, he will be like, I want to do this specific procedure, ablation procedure. I want to be semi-sedated. I want to do this and that. And the doctor's like, what? That's not what I was planning to give you. We have our internal procedure. Maybe that's more cost efficient for the payers. But what the patient just said, that makes total sense. That's exactly what they should be getting if you want to get the best care. So my personal experience is like when I go to the PCP, like PCP was like, you don't have to order that lipids panel. I don't know how much it costs, like $10. And I want that. I also want the cardio IQ, the more advanced stuff, because I know I need that. So I may kind of know this stuff more than the average patient, but just imagine that like through the society, like people learn those things, they start asking about those things. So there's technologies enabling this, but it's also kind of going to require some changes in culture, maybe in the entire system. Like, so I would imagine, like, say, United, Aetna, so they'll get a lot of pressure. If now, so you see their stock prices are really so much. How much of that is affected by the demand of care? Now think about if the whole society, how educated the patients are, and they're being their own advocate. So I think it'll be pretty massive changes.
All right, Jae, I'm going to ask you to bring us home with a healthcare system perspective.
Okay, so I think worst case scenario is if we repeat all of the mistakes that we did with social media. I think it's not a secret anymore and has not been for some time that, generally speaking, the World Wide Web has largely increased everyone's sense of fear and anxiety. We are objectively in a place where most places across the country are safer than they've ever been because there's surveillance everywhere thanks to technology. You can't do anything without being caught on 16 different cameras somehow, right? And yet there's a perception, if you ask people, how safe do you feel? You'll get a very different pulse, right? Similarly, I mean, with all these hyper-specific ads, you get fed FOMO on a daily basis every time you scroll through your phone. You get fed FOMO after FOMO. Well, that guy's got a private jet. No, he doesn't. He's sitting there and just paying someone to take a camera for $20. But it doesn't look that way, right? And so it's preying on very reptilian brain primal instincts of fear and anxiety. And I think if we allow AI to do the same thing in the healthcare space, which it already to some extent has been, with thanks to Dr. Google, we're going to have issues. I'll give you a more concrete example. You can go to any large language model right now, and you can ask it, how do you treat a peritonsillar abscess? I did it this morning just to verify, so hopefully there hasn't been an update since. 6 a.m. But you can ask it, how do you treat a peritonsillar abscess? And it'll tell you, oh man, you got to go get your throat cut. Someone's going to stab that and get it out of there, get that pus out of there. Yeah, that theoretically is one route to do this. But actually what I've done for over a decade, and backed by lots of research actually, is that we don't drain these anymore. That's not been the practice for some time. And this is when you realize there's a fee-for-service bias, because that procedure can make the doctor a couple $100 actually in the private practice world. So that's why that belief still exists, and that's why it's still there. On the other hand, in our system, in the value-based care system, we have not done that in over a decade. It's actually not been standard practice for over a decade. We've published research on it, and yet when someone, like a patient without that knowledge, would search for that in a language model, they get fed the fee-for-service bias. That's present. Does it come with footnotes? No, it doesn't. So that's one example, right? And think about how it would go in a physician's office when I say, hey, listen, my throat is really swollen, it hurts to swallow, I think I gotta get this thing drained. And then if the doctor tells you, hey, listen, we don't need to do that, we'll get you on some antibiotics, you'll still have the same 92% cure rate and it's gonna be awesome. That's a relatively easy conversation, right? Because you're thinking in your head as a patient, oh man, I came in here thinking I gotta get my throat sliced open, and now you're just telling me I gotta take some pills? Awesome, take that all day long, right? I'm not gonna be tasting my own blood and pus in the back of my throat. Amazing. Easy conversation. Harder conversation. Hey, I just did some searches on a language model, and it tells me that for my family member, the best way to treat this brain tumor is radiation therapy. And in fact, some of the latest research says that it'll eradicate it even. It could become cancer-free. Okay. I wouldn't advise that, because the location of this specific brain tumor is in your frontal cortex. Yes, the radiation may be able to blast it out, but it'll blast out everything that's in there. And your frontal cortex is what gives you personhood. All of us, we have humanhood by default, by our biology. That frontal cortex is what gives you humanhood, or personhood, and determines who you are as a person. And do you really want to blast all that and potentially sacrifice a lot of your actual functionality? And sadly, in this case, they actually did it. They found a radiation therapy center and effectively destroyed most of their frontal cortex. And so this person is now technically cancer-free. They had technically the correct answer. They are now cancer-free. They do not have any meaningful ability to interact with their loved ones. They do not recognize their loved ones, and they're in a care facility now costing a lot of money to just keep them alive. Is that an outcome anyone would want? I don't think so. But it's a harder conversation when you say, hey, listen, the AI suggested this, and this is technically the correct answer. And this is where I feel like judgment is crucial for that. What is the judgment for those values? And I'd like to see, and the positive aspect is really, I would like to see the judgment come to the forefront. I think we've long overdue, all these medical shows and whatnot, we kind of glamorize the doctor knowing everything. I think it's long past time we accepted that, no, we may not know everything, but we can apply a true human judgment. And I think that if that comes to the forefront, we'll win.
All right, that's a great way to wrap up. So please join me in saying thank you to our panelists.